Hello, everybody. Welcome to Grand Rounds today. Thrilled to have with us Dr. Daniel Caplivski, who is a professor in the Division of Infectious Diseases and the director of the Mount Sinai Travel Medicine Program. Went to Harvard College, Yale Medical School, and then has been at Sinai after that for residency and fellowship. And always a pleasure to hear him talk, not only because of his content, for which he's won a number of teaching awards, and also for his incredible photos. We're looking forward to it today as he speaks about vector-borne infections. Dr. Caplivski.
Okay, thank you so much. It's so great to be with everyone today. Yeah, so I'm always interested in speaking about vector-borne infections. I feel like they're so interesting and there's so much to discuss. Um, I wanted to start with a couple of basics. Basically, I have no financial disclosures to talk about. And I wanted to cover some of the objectives for the talk. I'm hoping to define zoonotic infections and within them the vector-borne infections, to describe some clinical manifestations of vector-borne illness like Lyme disease, and review some of the clinical management of these infections as well. And then I'm hoping to speak a little bit about the vectors themselves, because I think it's helpful to think about biology of ticks or mosquitoes or mites, just to understand a little bit more about how these infections are transmitted. And yes, definitely throughout the talk, please feel free to use the chat for questions or just, feel free to interrupt me, and I'm happy to talk about any subjects in more detail. I think it's always fun to hear, patients you've seen or questions you've had with different clinical cases. Great. So what is a zoonosis? Well, zoonoses are infections in which the organism can be passed from animals to humans. They include infections in which are transmitted by insect vectors, so malaria, for example. And animals, it's important to remember, can be reservoirs even though they may not manifest disease when they are infected. So I put up a few clinical pictures here just to show you a little bit more about the classic zoonotic infection, which is anthrax. So Bacillus anthracis, this is an organism that infects animals like this zebra with hemorrhagic disease. And some of the spores of anthrax can survive in the soil or in their hides. When humans come into contact with those spores, they can get a cutaneous versions of anthrax that's characterized by this very dark necrotic eschar. There was a case, back in around 2003 when a man in Brooklyn was stretching out some animal hides to make West African drums and ended up getting inhalational anthrax. And that was at a time when we had just gone through bioterrorism with anthrax. So there was a lot of public health interest in understanding this disease again, which has been known about for centuries, but kind of reappeared as a reemerging pathogen more recently. So these are some of the actual vegetative forms of Bacillus anthracis, and all of what we know about anthrax really goes back to a couple of our the founding fathers of microbiology. So this is Robert Koch and Louis Pasteur. Koch was the physician scientist who was able to isolate Bacillus anthracis, and Pasteur, very well known for developing the rabies vaccine, had actually worked on an anthrax vaccine in the late 1800s. So I mean, it was a problem for livestock. It was a problem for people who were herding sheep, for example. And he had developed this vaccine that protected sheep against infection. And so I think our understanding about microbiology is really linked to our understanding of infections in animals. And today I'll be paying particular attention to those that are transmitted by insect vectors. But I think zoonotic infection in particular is very worth our time and thinking about. And obviously with COVID-19, we're looking at the origins of that as potentially a bat coronavirus that maybe passed through another animal and then onto humans. But obviously zoonotic infections are really fundamental to understanding of infectious disease. So today what I really want to cover are things related to skin manifestations of disease in particular, because a lot of these vector-borne illnesses you'll see are in fact going to be manifesting with an initial skin presentation. So here's an example. This is a 27-year-old man with severe fatigue, fevers, chills, night sweats, and headaches. He spent some time on a farm in northwestern Connecticut. And if you look on the back, so you can see sort of this classic erythema migrans bullseye rash. And you get a very classic presentation of early Lyme disease. You might also see patients with, sort of this more classic lesion on the abdomen, but some other lesions that may not look as, sort of classic for that spreading bullseye. And this was a woman who had these after spending time in Massachusetts in the summer. Other sort of interesting later manifestations of Lyme can include more disseminated erythema migrans rashes. So we classically think about the initial rash being the inoculation site of the tick bite, and then the Borrelia burgdorferi kind of spreading from that initial site in waves throughout the skin. And later it gets into a disseminated phase in the bloodstream and goes to other organs like the knees or the joints. But there is a later phase in which it can spread, again, via the bloodstream and end up back in the skin. So you might see an example like this. This was multiple EM rashes and a cranial nerve 7 palsy after visiting the Staten Island Nature Center, this patient who had multiple skin lesions throughout the body. So basically, we're talking about a spirochete, Borrelia burgdorferi, that is not very good at growing in petri dish. So we are very sort of stuck with alternative diagnostic methods, mainly clinical appearance. So, just being able to see that rash, but also tests like serology and at times PCR. So I wanted to go through and talk about the vector here. So the vector for Lyme disease is this very small black-legged tick called Ixodes capillaris. So in its nymphal stage, we're talking about something about the size of a pencil point. As they get to adults, they're a little bit easier to see, and when they're engorged, so easier to see. But these are very small and easy to go unnoticed. I'll mention a little bit about lone star ticks and dog ticks as well. It'd be helpful for us to kind of recognize the differences there, because sometimes we can give patients some reassurance about whether or not they're at risk for Lyme disease when they're in endemic areas. So the basic Borrelia burgdorferi life cycle is transmitted from ticks, often from white-footed mice, which is their main animal reservoir, to humans, but also to other animal reservoirs, including deer. So deer tend to be very important for their adult stage. So those are the mammals that they're more likely to encounter during that winter time. But as humans, when we spend more time outdoors in the spring and summer, we're more likely to be encountering some of those larvae and nymphs. And those are probably going to be the ones that are harder to see, so that they're responsible for most of the human disease. Geographically, Lyme disease is obviously very endemic here in the Northeast. Here in New York City, we tend to see a lot of people who have summer travel either out to parts of Long Island, upstate New York, Massachusetts, Connecticut, throughout the Northeast, New Jersey. So, and including here in Staten Island, where there have been some cases among people that just come into contact in nature centers, for example. So always good to keep in mind in our geographic vicinity. There are also important foci in the Midwest and to some degree in Northern California, although the epidemiology there has been trending downwards to some degree because of the droughts. So certainly up in our neighborhood, lots of reasons to be thinking about Lyme disease. The early localized manifestations tend to happen in the between day 3 and 30. Usually they're at the site of that bite of the tick, and we are usually looking for this classic bullseye rash or erythema migrans. Most of the time, these patients have relatively mild systemic symptoms, but some of them can have pretty significant fevers and chills and sweats. So if we miss the rash, we can still be looking out for those early symptoms. Later disease or in the next phase of this, we can get some early dissemination. And that's usually about 1 to 4 months after the bite. And that's where you might see some nervous system involvement. A lot of this can be cranial nerve palsy. So, you can see an example here of a Bell's palsy. In some patients, you may actually encounter lymphocytic meningitis. The cardiac involvement can manifest with things like a complete heart block. So some of those patients will end up hospitalized for cardiac monitoring. And you can see that disseminated rash that I was showing examples So in late disease, 3 to 4 months to years after that bite, you might see some intermittent arthritis. Knee and other large joints are particularly joints where we see this a lot. You might see 1 or 2 joints involved. Some of those patients will develop some chronic arthritis despite treatment. We think that some of that is probably immune mediated. We don't think that long-term IV antibiotics are really so useful in that scenario. And then chronic neurologic symptoms. So that might be, axonal disease with radicular pain or paresthesia. Lyme encephalopathy is also a small portion of those patients as well. So the vast majority of the patients we're going to see presenting are probably going to be in this early erythema migrans phase. A lot of people I think who are in these endemic areas are sort of used to looking for those rashes and looking for ticks, but that's not always the case. So they may come in presenting just with that erythema migrans rash. They may also present just with a single joint arthritis, classically the knee, a facial palsy, or radiculopathy. And then less frequently in the inpatient wards, we're sometimes consulting on patients who have meningitis or encephalitis, and there is concern for that possibility of Lyme disease as well. So how do we diagnose Lyme disease? Early on, the clinical picture is probably your best bet. If you see that classic spreading rash, you're probably able to rely on that as a diagnosis and treat appropriately. Certainly serology has an important role. The early diagnosis of Lyme can sometimes lead to some false negative tests because your antibody response may not be adequate, sort of get to that threshold of what's considered a positive by the CDC. So if you look on your reports for Lyme disease testing, usually there's a caveat that to be considered positive, there needs to be at least 5 IgG bands on the Western blot. And that's because we have a fair number of false positives. So other spirochetes that have been in our mouth, viral infections, lupus, other blood-borne infections can sometimes lead to some false positives. You get 1 or 2 positive IgG bands. Borrelia Burgdorferi infection. So a prior infection may leave behind a few IgG bands, so that might lead to some false positives. You can also have the phase where you've got, let's say, 3 IgM bands, but you haven't yet developed all those IgG responses. So timing on that serology test is important. And if we're not sure, sometimes we will repeat the test in 2 to 3 weeks for confirmation. I would say PCR is sometimes useful in scenarios like arthritis or CNS disease, but its role in terms of bloodstream infection has really not been established. And there's some mentions in the guidelines also about PCR testing of ticks, which you'll sometimes see reports of, which don't really accurately predict infection. So I would say even if you've got someone who's got a negative PCR on a tick, and they're presenting with a classic erythema migrans rash, I'd say you're still going to proceed with treatment. Cultured stains not routinely used in clinical labs. It's just not an organism that's very amenable to routine culture. And our treatment are mainly with oral antibiotics like doxycycline or beta-lactams, such as at times you're using intravenous antibiotics for more severe manifestations such as heart disease or CNS. But even in those cases, a lot of times we can pretty rapidly transition over to oral antibiotics. So the clinical practice guidelines from the IDSA and the American Academy of Neurology, College of Rheumatology were just updated in 2020. So it's very helpful to use as a reference if you have any questions about diagnosis or treatment of Lyme disease. They just had an IDSA session at ID Week as well. They kind of went through these guidelines and highlighted some of the updates. So I think that's a useful reference if you're looking for specific clinical questions. They include some very useful tables, and I think it's nice to kind of go through different scenarios in terms of what's preferred. I would say for most of our adults, we tend to favor the use of doxycycline in our neighborhood because we have a fair amount of co-infection, or at least risk of co-infection with anaplasmosis. And doxycycline has that benefit of being active not only against Borrelia burgdorferi, but also against the Anaplasma phagocytophilum. Amoxicillin, however, would also be effective. Cefuroxime are good oral agents. For people who can't take these because of allergies or other intolerances, azithromycin is a secondary choice. And then some scenarios where we do need intravenous antibiotics, ceftriaxone is excellent. There are some scenarios where it can be given as an outpatient 3 times a week, but I would say for most of our inpatients, we're using the 2 grams daily dose. So treatment durations are also, I think, a question that come up a fair amount. For early disease or erythema migrans, you're probably going to be just fine with 10 days on doxycycline. For some of the later manifestations involving either CNS disease or carditis, then we're talking more like on 14 to 21 day range. And then for some arthritis that's sort of really more difficult to treat at times, a 4-week course is reasonable. And then sometimes that gets repeated for refractory disease. So again, some of the tick identification becomes important when we're trying to distinguish between Lyme disease and some of these more emerging illnesses like southern tick-associated rash illness. And that's related to this Lone Star tick. If someone comes in with this particular tick attached to them, and you can confidently say that there's no risk of erythema migrans being from Lyme disease, you can decide not to treat that. But I would say for most of the patients we're going to see a lot more exposure to Ixodes scapularis, and that's, if you're seeing this rash, you're probably going to be treating most of those patients. Okay, and then I wanted to move on a little bit to another tick-borne illness that we see a fair amount of every summer. This is a 47-year-old woman who presents with fever of unknown origin, generalized malaise, and anemia. And she was admitted to our hospital, and she was getting annoyed that our inpatient evaluation was keeping her away from her house in the Hamptons. And that turned out to be an important piece of the story. And sometimes this catches us by surprise, but this was a lab technician who called and said, "Did you know that this person has some organisms inside their red cells?" So what we're looking at here is the ring of Babesia microti. And Babesia is so sneaky because, it's one of these causes of fever that, again, doesn't grow in the blood culture. So we really need to be looking for it on a parasite blood smear or checking antibodies or PCR. But it can really kind of sneak up on you. So Babesia is typically transmitted by the same ticks that carry Lyme disease and Anaplasmosis, which I'll cover next. These are intraerythrocytic parasites that are almost impossible to distinguish from Plasmodium, the agent of malaria. But sometimes you might see, like especially on a board exam, if they give you these 4 merozoites kind of arranged in a tetrad that almost looks like a cross, then you're dealing with Babesia. All right, so that's the Maltese cross formation of babesiosis. But if you just see the intracellular rings, it's really hard to tell if this is an agent of malaria or Babesia. They're a little bit smaller maybe than Plasmodium, but otherwise they're pretty tough to distinguish. So treating the typical Babesia case usually involves atovaquone and azithromycin, all oral regime. Usually that's a little better tolerated than clindamycin and quinine, fewer side effects. I will say that some patients that do have more severe cases of babesiosis, they've had a splenectomy or they've got some sort of immunodeficiency, they've got a higher level of parasitemia, we will use clindamycin and quinine, and even other combinations that include these two plus atovaquone and proguanil. So there's different variants on that, but for most of your patients, you're probably going to be using atovaquone and azithromycin. So interesting, unlike malaria, this does have an animal reservoir. It's also those white-footed mice that are a reservoir for Lyme disease. So again, here's some more of the epidemiology of the ticks. So in our region, we're mainly seeing Ixodes scapularis. In the Pacific coast, they're going to see Ixodes pacificus. Amblyoma americanum is mainly in the southern part of the U.S., and there's some overlap as well with Scapularis and americanum in the southeast. So Babesia is interesting because some people are completely asymptomatic from this. They really never really mount a fever response, or they just clear the infection. It's a big problem for blood transfusions because a lot of our donors may have had an asymptomatic infection. Then when they donate blood, they don't realize that they're actually donating Babesia as well. There's some mild to moderate illness, 1 to 6 weeks in, that can include malaise, fatigue, and fever. Some people get really profound sweats with this, where they're really drenching, just like in malaria. With the severe fulminant illness, these are usually people who are asplenic or otherwise immunosuppressed. These complications include respiratory failure, DIC, CHF, liver, and renal failure. So those really like the worst cases of malaria can overlap a lot with this as well. And a lot of people won't recall that tick bite, again, because these are nymphal ticks that are very easy to miss. And you don't get the erythema migrans rash, so if they attach and then transmit the infection and detach, it's easy to miss them. There's an example of babesiosis that also kind of snuck up on us. This is an 85-year-old man who presented with fever, chills, and a hemolytic anemia. He was bedbound and really didn't leave East Harlem. He also had some cirrhosis and had some chronic blood loss. So he had an admission about a month before he presented to us, in which he got a couple of units of blood transfusion. So it wasn't really on our radar, but again, we got a call from our laboratory, very astute technician that looked at the manual diff and peripheral blood smear, and noticed that inside of these erythrocytes we could find some rings. And you can see that they have a tiny chromatin dot. I think in this particular red cell, you can see that there are 4 of these little merozoites. Once in a while, I'm looking around this one, and sometimes you'll see a platelet that looks a lot like Babesia. But once in a while with Babesia, you'll catch some extracellular forms, and those can also be a useful clue for diagnosing this and distinguishing it from malaria. So how does an 85-year-old man who's bedbound in East Harlem get Babesia? It's from blood transfusion. So when we went back and contacted the blood center, they sent some letters to the donors who had given him the units, and they tracked down, and they were able to find that one of them was antibody positive for babesiosis as well. So the normal sequence of events is that this is an organism that kind of gets transmitted from one mouse to another, usually via the ticks. These ticks are feeding on the mice, and then sometimes they will end up infected with this organism. And then when they go on to feed on a human host, they transmit that infection. And these sporozoites head for red cells, and they begin to divide asexually and sometimes form this classic Maltese cross. Sometimes they'll escape and you'll see some extracellular forms. And then what happens is that sometimes an asymptomatic infection in someone who's donating blood can lead to a secondary infection in someone else who's received that unit of blood. So it's an interesting problem for blood centers. I'd say this is some older data from between 97 and 2007, where we could see that there was some increasing rates of blood transfusion associated with babesiosis. I think that the fact that now our Babesia PCR is FDA approved and licensed is going to make it easier to screen for. But I think it's good to kind of keep in mind, especially if you have patients who are hematologic malignancies or other scenarios where they're getting a lot of blood transfusion, to look out for Babesia as a cause of fever of unknown origin. All right, so just a little history on babesiosis. Gets its name from Victor Babesh, who's this Hungarian microbiologist who described it as the cause of an outbreak of fetal hemoglobinuria in cattle. And this is just, since we just had Passover and Easter, I figured this is from Exodus 9, where you have maybe a reference to some illness that causes disease among a lot of livestock. And there's some theories that maybe that was babesiosis. Okay, so now I was going to move on to a few more vector-borne illnesses. This was the story of a 72-year-old hiker. So a 72-year-old woman who was very, very active. She had been hiking in Peru several months prior to admission with fever, confusion, and unsteady gait. She also did a lot of hiking every week in Harriman State Park, upstate. And, so already you got a couple of epidemiologic clues as to what are the possible causes of fever, confusion, and unsteady gait in someone like this. Well, she was being evaluated in our hospital, and she had some laboratories drawn. They included a very low white cell count of 1.3. She had a hemoglobin of 13. Her platelet counts were also very low. She had 24,000 there. So we got leukopenia and profound thrombocytopenia. Some elevated liver enzymes with an AST of 345 and an ALT of 442. And the total bili was 1.3. So she gets admitted to our MICU after, kind of getting worsening confusion on the floor and progressive dyspnea. And the answer in this case was also on the peripheral blood smear, although not inside the red cells. So in the red cells, you might look for organisms like malaria, or, because she was in Peru, you could look for Bartonella, Bacilliformis, some of these more exotic things. but she probably acquired this more locally, and it was inside of the white cells. If you look closely here, you can see some concentrated chromatin. These are actually the morulae of anaplasmosis. So anaplasmosis is a very interesting organism. Kind of got renamed from ehrlichiosis. There was the human granulocytic ehrlichiosis and human monocytic ehrlichiosis. And then they just gave a whole new genus name to human granulocytic ehrlichiosis. So this is the one that we have more commonly in our neighborhood compared to human monocytic ehrlichiosis. So it's a zoonotic intracellular bacteria. It was initially described in animals like dogs, but now we increasingly see it in humans. It's a really hard organism to culture in media. So most of the diagnosis is made clinically, just finding someone who's had a tick exposure and has leukopenia, thrombocytopenia, and elevated liver enzymes with fever. And then you can confirm it with serology. Now, PCR testing has become much more available. So you may be able to make this diagnosis also through PCR. If you do have a peripheral blood smear on a patient like this and you look around, you might actually see some of these morulae, which are basically concentrated intracellular bacteria. And here's the picture of a tick on a prescription pad, just to give us a size reference for how small Ixodes is. And this is what it looks like when we magnify it. So I did want to mention, just before we leave anaplasmosis, typically treatment here is with doxycycline. So again, when you're treating Lyme disease with doxy, you're also getting good activity against anaplasma. And for most of these patients, they're going to get better within about 7 days of the doxycycline. So you can do confirmatory testing with serology, 3 or 4 weeks later. But usually once you've seen that kind of a response to doxycycline, you have a good confidence. And this patient who was actually admitted to the NICU did great after a few days of initially intravenous doxy and then transitioned over to oral doxy once she was more alert. Okay, great. So I wanted to just mention Powassan virus just because it's one of these emerging pathogens that over the last decade or so we've started to see a few more cases of. So it's another tick-borne infection from Ixodes. It's going to be a cause of meningoencephalitis, and I'd say most of the cases in our region are happening in upstate New York, Massachusetts, parts of Maine. So just be on the lookout for that this summer. If you have patients admitted with altered mental status, and there's some concern about tick-borne infection, the New York State Department of Health up in Wadsworth can run PCR testing for Powassan. Okay, now to move on to a few more exotic kind of infections related to ticks, I wanted to talk a little bit about these cases. So this is a 57-year-old woman who returned from a 10-day trip to South Africa and Zimbabwe with the lesions shown here. And this is kind of behind her knee. In Zimbabwe, she had visited some game parks, and in order to get to an outhouse, you kind of have to walk through some very tall grasses and shrubbery. And this on the back of her knee is kind of a necrotic lesion. It was actually pretty painless. On Tuesday night of her return, she felt decreased energy, and then by Friday, she already had some fever and chills. She was not taking malaria prophylaxis. She denied any other symptoms or skin lesions, no disseminated rash, and she denied any freshwater exposure. So, when you see a necrotic lesion that's black like this, there's a few things that come to mind. I mentioned in the beginning of the talk, anthrax, so Bacillus anthracis is one that can certainly produce a necrotic lesion. And if there's cutaneous exposure to the spores of anthrax, you might be thinking about that. There are brown recluse spider bites that can look a lot like that, known as loxoscelism. So if you get bitten by one of these spiders that has a venom that's very sort of toxic to the vessels of the skin, you can get some ischemia and necrosis. Most of the time, those are fairly painful lesions. This one was actually pretty painless. And it was accompanied by all these other systemic symptoms, the fevers, the chills. And just geographically, when you have a necrotic lesion like this, called a tache noire or black stain, and you've got a travel history of South Africa, you can be thinking about African tick bite fever. So this is a rickettsial infection caused by Rickettsia africae. It often presents with this typical eschar at the site of the bite. So, these are the ticks that they have in southern Africa, and they transmit this tiny intracellular bacteria, which has a predilection for the vessels. So it gets into the endothelial tissue, and it causes enough of an infection that you actually lose some of the blood supply to that skin. So that's where you get that very dark ischemic area. And then it disseminates more widely. You get those fevers and sweats and more disseminated infection type symptoms. Sometimes you will see a more disseminated rash along with this. So here in the United States, the closest equivalent would be the Rickettsia rickettsiae infection of Rocky Mountain spotted fever. That typically does present with a large, very noticeable rash that sometimes involves the palms and soles. Rickettsia africae can present just with a tache noire and no other rash, and then you just got to kind of go on the epidemiology and the fevers to try to make this diagnosis. So you have something like this, and most of the tick-borne infections will respond to doxycycline. You treat them with the doxycycline, they get suddenly better. Then, in a few weeks, you can get your serology testing. Again, sometimes PCR is available through the CDC for some of these agents that are more exotic for us here in the United States. But this is kind of the geographic range of African tick bite fever. In Southern Europe, they have another type of rickettsial pathogen called button nose fever. So this, sort of different species depending on the geography. But generally, the treatment of doxycycline is very effective for all of them. Most of the prevention here is with insect precautions. So that's, DEET-based repellents, permethrin for the clothes, sleeping under mosquito nets in particular for nighttime feeders like Anopheles with malaria. But, in particular, I would say more and more safari travelers were presenting with this tick-borne infection. So as soon as we get travel up and running again, I'm sure we'll start dealing with more of these kind of cases. All right, so this is a 27-year-old woman who developed a papule on the wrist. And a couple of days later, she developed fevers, chills, drenching night sweats, a diffuse macular rash, and tender right axillary lymphadenopathy, along with some extreme fatigue. So she had actually traveled to Zambia, but it was 4 years prior. So it was really a long incubation period for it to be something related to that trip. But she did work for the Department of Education in kind of an older building. And there was a lot of, we asked her about this. We asked, have you seen any rodents like mice or rats? And in fact, she had. So, you can see that this evolved from sort of a reddish papule to a more clear tache noire black spot. And this is a local infection with the rickettsial pathogen we have here in New York City, and that's rickettsial pox. So Rickettsia acari is the name of this species. It was first described here in Queens, New York. It's transmitted by very tiny mites that often feed on rodents like mice. So humans, we don't always directly come into contact with the mice, but if the mites are close by, they can transmit this rickettsial infection. So, and again, usually it's the inoculation site where the mite is biting that leads to this local ischemia from the rickettsial pathogen. So in this patient had been working in this older building where she'd seen some rats and mice. And so these rickettsial infections can be a little bit difficult to pick up on immediately. Again, we can't grow them in blood cultures. You have to be sort of thinking about them and looking for these kind of rashes or asking questions about rodent exposures. They'll help you get to that diagnosis. So here's just a list of some of the different rickettsial pathogens. So Rocky Mountain spotted fever is transmitted, is caused by Rickettsia rickettsii, which is transmitted by a tick. Rickettsial pox here in New York City by Rickettsia acari, and that one is mite-borne. Some of the ones that come up more like on boards, we don't see as much here, like scrub typhus and epidemic typhus, can be mite-borne or louse-borne. And then there's murine endemic typhus from Rickettsia typhi, which is flea-borne. So lots of different types of exposures you could think about. I would say here in New York, Rickettsia pox would be the one we'd be thinking about most. Okay, so I wanted to move on to a few more interesting infections related to vectors and often presenting with skin manifestations. So this was a case of skin lesions in a patient who had returned from Costa Rica. So he's a 33-year-old man. He was healthy otherwise. He spent about a week in Costa Rica in early April. And he had done some river rafting. We were staying in some lodges that were kind of open air, so didn't have any sealed windows or mosquito nets or anything like that. About a week after he came back, he noted 3 lesions on his left wrist, and he thought they might be spider bites. But then he noticed that there were 3 more lesions on his flanks, a couple on the left and one on the right. And he was actually a veterinarian, so proximal to that wrist lesion, he was able to palpate some subcutaneous nodules on the inner surface of his left arm that he recognized as swollen lymph nodes. So when he came into the office, this is what we were looking at. So here you can see these are skin ulcers. They're a little bit confluent. They have a border that's a bit raised and erythematous. These, for the most part, were fairly painless. They've been going on for a few weeks, and he tried different topical antibiotics that hadn't really improved anything. These were the lesions on the flanks. Again, sort of ulcers surrounded by some erythema. Sometimes you get some scattered satellite lesions that develop a little bit more into ulcers as well. But it's mainly this central kind of volcano appearance that draws most of the attention. So to get to our diagnosis here, one way is to take a little bit of the material from the base of the ulcer, just with an 18 gauge needle, and just put it on a slide and do a diff quick, quick Gms stain. And when you do that, you look under the microscope, you can actually see some of these organisms sometimes. So just to orient you, here are his human red blood cells and a human white blood cell. This phagocytic cell has its own nucleus, its cytoplasm. And inside, you're actually looking at some amastigotes of a protozoan parasite. So here's the nucleus of the parasite, and here is the kinetoplast. It's kind of like a tiny bar-like structure that you'll be looking for when you're diagnosing this. Once in a while, you'll see a few extracellular examples, but the intracellular ones are usually the ones that we're most likely going to encounter. So this intracellular parasite causing this painless ulcer in this patient returning from Costa Rica was Leishmania. And this particular species was Leishmania penamensis. So how do we get to that answer? In addition to taking the cutaneous scrapings, we just did a skin biopsy with dermatology. Some of that tissue went to our path lab. Some of it went up to the CDC, where they can do PCR and culture to grow Leishmania and just give us an exact species name, which is always very helpful when we're deciding on treatment. So this is an organism that transforms. It's very interesting. So in its phase inside of the insect vector, the sandfly, it exists as what we call the promastigote. So the promastigote has a flagellum. It's got this tiny bar-like structure, the kinetoplast, which is kind of like a motor or engine for that flagellum. And when the sandfly takes a meal, it transmits this flagellated form, the promastigote, into the subcutaneous tissue. These are very highly motile, and they're actively looking for macrophages, the very cells that are designed to destroy invading pathogens. But they're evolved to survive inside those macrophages and basically transform into the amastigote phase. So they lose the flagellum. They're tiny intracellular organisms. They start dividing and surviving very well, and then they rupture out of those macrophages and go on to infect other cells in the area. So the cycle continues when another sandfly takes a blood meal, picks up the amastigote phase, and they go through further transformation in the insect vector. So the other important things that happen in the human body is that as these replicate, they can start to generate inflammatory response, and that can lead to that cutaneous ulcer at the site of the bite. Some people are bitten in multiple spots, so that's why you can sometimes see them in other areas. Some of these organisms, months or even years later, can sometimes disseminate to the oropharynx and cause what's called mucocutaneous disease. And some of them can disseminate to the liver and spleen and cause what we know as visceral leishmaniasis. I put a small box here just because animals are an important reservoir host. So canine reservoirs in particular are important in the life cycle of Leishmania, and it's part of the challenge of controlling this in terms of public health measures because we still have an animal reservoir to deal with. So Leishmania is identified in many, many countries: Africa, Central and South America, Europe, Asia, Middle East, many different continents. You've got around 2 million people infected, but over 350 million people at risk. There's this large spectrum of clinical presentation that ranges from a simple cutaneous ulcer to devastating mucocutaneous disease, as shown here, which can be very disfiguring, visceral disease, which can be lethal. And a lot of that really depends on the species. So, as I mentioned, these are intracellular parasites that are designed to inhabit the immune cells that are there to destroy invaders. So they're highly evolved. But we do see a big variability in terms of species and host in terms of those clinical manifestations. And I mentioned the reservoir host in terms of rats, dogs, and other animals. So the disease correlates with species and geographic region. That's just shown here. Here's an example of cutaneous leishmaniasis. Typically, things like Leishmania mexicana or tropica will present this way. Mucocutaneous disease can be caused by Leishmania brasiliensis or Leishmania panamensis, as was the case in this particular presentation. And that can be very disfiguring. You can lose, the nasal septum, the whole nose can be destroyed. This is some pre-Columbian pottery, just showing this is probably a very old disease. And then visceral leishmaniasis from L. donovani, which we'll see in parts of India and Southern Europe, can cause this massive hepatosplenomegaly with fevers and sweats and eventually, in some cases, fatal infections. And all caused by a vector that's very tiny. Sandfly bites can be very easy to miss. So patients with this don't always present with, having had a lot of insect bites or anything like that. So diagnosing leishmaniasis involves several different techniques. Some of it is relying again on this clinical appearance. So if you see a cutaneous ulcer with a raised border, it's typically painless. If you see a proximal lymph node nodule that's enlarged, that's always very helpful and kind of distinctive. But you can definitely go directly to the source and scrape some of this tissue, put it on a slide, and you can see those amastigotes. With the CDC, there's a great website called DPDX that assists with making parasitic disease diagnosis. So if you want to send them a clinical image of the ulcer and then maybe some of the pictures under the microscope of the amastigotes, they can certainly help that way. They're also happy to receive clinical samples, so tissue biopsies, scrapings, other ways to get the material for culture and PCR. So the culture of Leishmania usually leads to the growth of these promastigote phases again. And if you look at this in a wet mount, they're actively swimming around the media. We don't routinely do this in our commercial labs, but again, at the CDC, they can get these to grow. If you are going to send them a specimen, it's always ideal when you know ahead of time that you're going to get a patient with leishmaniasis. Sometimes we'll refer this kind of a scenario from dermatology, for example, just because then you can order the special media and materials that you need to get this directly inoculated into PCR fluid for the CDC. But even if that's not the case, and you just get a fresh tissue into some saline and send it to the CDC or to Wadsworth, upstate New York, they can work with that and they can get us a good yield on figuring out what species we're dealing with. Sometimes you're going to find this on biopsies of other organs like the liver. And there you're typically going to see just many of these cells infected with these tiny little organisms, which are the amastigotes. So it often does take a lot of careful hunting around to find leishmania for a pathologist because they're used to looking at 10 or 40x, and these are organisms that you see best at 100x under oil immersion to really be able to see the kinetoplasm. They also mimic histoplasma. So for especially a liver biopsy, it can be easy to look at this and say, well, this looks a lot like the yeast form of histoplasmosis. But the distinguishing feature here would be the kinetoplast, which is that tiny bar-like structure. So the CDC sometimes asks about that if you're considering this diagnosis. Serology has some utility, although it's a little bit less useful, especially for cutaneous disease, because a lot of those patients may not actually mount an antibody response if it's just kind of isolated to the skin. So treatment of leishmaniasis is a little complex in the sense that our traditional treatment of this was with pentavalent antimony, and it's an intravenous therapy that's not very well tolerated. It's only available through the CDC's drug service. It's not FDA approved in the United States. It's just under an IND, Investigational New Drug Protocol. So, and it's a 20-day to 28-day infusion of an IV antibiotic. So it's not very palatable for most of our patients. For depending on the species and the clinical manifestation, sometimes observation alone is fine because about 30% of those lesions do get better on their own, and that's higher for L major. For more locally, we see a lot of L mexicana, and those really do well. But some of these other ones like Panamensis have this particular tendency to go to the oropharynx. So we really want to be a little bit more proactive with those to try to prevent those complications. And so yes, the pentavalent antimony is available as an option. We're seeing more and more data for amphotericin. So amphotericin is an antifungal, but it's very useful for the treatment in particular of mucosal disease, because a lot of times that's very refractory to treatment with pentavalent antimony. And we're starting to get more and more data on this oral agent called miltefosine. So this is a study from a group of physicians in Colombia who were working with farmers in Bolivia where Leishmania was endemic. And a lot of them had mucocutaneous manifestations. And, the traditional therapy for this would have been, 20 to 28 days of IV either pentavalent antimony, or if they could get access to it, amphotericin. So the advent of an oral agent was a really big improvement. And the results were great. I would say for a lot of species of Leishmaniasis, oral miltefosine has great efficacy data, very well tolerated. It's typically just going to cause a bit of nausea. It is a teratogen, so that's one issue for us in patients who, women patients who may become pregnant, during the course of therapy, something to be aware of. But for a lot of patients, it's a really excellent choice. This is 4 weeks of therapy, and then several weeks later, it had excellent healing of mucosal leishmaniasis. So in the United States, this agent recently got FDA approval, and its actual direct indication was for treatment of free-living amoeba. So those brain-eating amoebas you'll sometimes hear about, like acanthamoeba, Naegleria, they're sometimes treated with miltefosine, but it actually has excellent activity against Leishmania. So for our patient who had been in Costa Rica, we obtained it through an investigational new drug protocol because at the time had not yet been FDA approved. But he was very happy to not have to go to the hospital for intravenous amphotericin. He got 4 weeks of the drug and had an excellent clinical response. So very good healing. This is about a month after he completed therapy, and then a year later, you couldn't really see anything of the scar, and no dissemination to the mucous membrane. So I think miltefosine is exciting. It's not going to be effective for all species of Leishmaniasis, but certainly for some of the ones that it's got good clinical data, it's a very good option. But I think the big picture on Leishmania is that its epidemiology includes the tropics, but also parts of Southern Europe. The transmission is mainly through this tiny sandfly vector. It's got some reservoirs like rats and rodents and canines. The clinical manifestations depend on the species, but they can include cutaneous disease, mucocutaneous disease, and visceral disease. And typically you're making a diagnosis by looking for these hemastigotes on the biopsy through skin scrapings. You can grow it and do PCR by sending samples to Atlanta for the CDC to work on. Serology can be helpful in some cases of visceral disease, but I would say more typically cutaneous disease is better diagnosed by directly looking at the tissue. Treatment includes pentavalent antimony as traditionally our drug of choice, but I would say amphotericin B much more readily available and easier to manage. Short courses of amphotericin B also seem to be very effective. Sometimes even single dose therapy at high levels like 20 milligrams per kilogram have been effective at curing visceral leishmaniasis. And then oral miltefosine, I think, has got a bright future for managing leishmaniasis as well. So I think I got one last skin case related to a vector, and this is a patient who returned from ATM. So this is a 29-year-old man who's not a Sinai student who returned from Belize with a skin lesion behind his right knee. So we had just gone to Belize with a group of medical students from Mount Sinai, and a lot of them had gone on this trail called the ATM Adventure Trail. And this patient had as well. He had been snorkeling in the Keys, but went through this jungle tour of the ATM Adventure Trail. And he came back with a skin lesion behind his knee. So it reminded me of the skin lesion I'd seen in Peru. There's a great tropical medicine course in Lima and Cusco and Iquitos called the Gorgas course. And they put all their cases online. So if you're interested in tropical medicine, it's a great resource. But this was one of the cases we saw when we were up there in the northern jungles. This is a 51-year-old woman with a tender erythematous expanding lesion on her arm. And 3 days prior to onset, she returned from a 2-week stay in the jungle region of Pucallpa. So you can see that the skin lesion is a bit erythematous, but in the center, there's a black spot. And that's not a tache noire or a necrotic lesion or anything like that. That is actually a breathing hole. Okay, and what is below the surface is the larva of a botfly. So when you kind of occlude this with some Vaseline or something else that's going to cut off that breathing supply, usually what's going to emerge is this larva. Okay, so mycenaesis is the name of this disease. It's caused by in this case, Dermatodium hominis, which is a fly that captures a mosquito in flight and glues her eggs to the abdomen of the mosquito. And then when the mosquito takes a bite of some other mammal, it deposits the eggs and they kind of burrow under the surface. And then slowly this thing grows. So, I saw the patient who had been to Belize. I said, this really looks a lot like a botfly bite. It turns out that's pretty endemic in this part of Central America. But when we tried to occlude this little breathing hole, it really was not fully emerging. So what we ended up doing was a excisional biopsy, and then this is what the larva looks like in cross section. And this is the botfly. So it's a very large black fly. It captures the mosquito in flight. It's depositing the mosquito is depositing those eggs for the fly on a mammal, and then they burrow under the skin, and then they've got these basically a breathing apparatus up here. It's very hard to excise these just with tweezers alone. So the ideal scenario is when you just occlude use occlusive therapy to get them out. But in some cases, they won't, and so an excisional biopsy can get the whole thing out, and that was the case here. So generally, these don't lead to any disseminated infection. There's no bacteria or virus, but I thought that was a helpful one to be aware of, just in case you're seeing more skin lesions as travel starts to ramp up again, as this pandemic starts to get better. So I think I'll summarize just some of the parasites and their vectors. Leishmaniasis, I talked a bit about today, is a protozoan parasite transmitted by the sandfly. 2 different genuses here, Luxemia and phlebotomy. Chagas disease, I didn't really cover today, but it's related to Leishmania along with African trypanosomiasis. These are transmitted by the kissing or reduvid bug or the tsetse fly. And then we talked a little bit about Babesia species transmitted by the Zonosis tick. They look very similar under the microscope to malaria, which is transmitted by the Anaplasmosis mosquito. And then a few kind of neglected tropical illnesses like filariasis and river blindness are transmitted by various species of mosquitoes and the black fly, Simulium, as noted here. I think the big intervention in terms of prevention tends to be insect precautions. So, anything with like 33% DEET will last good 12 hours for most people for their skin. And then for clothing and gear, any kind of Picardin or these kind of clothing treatments, permethrin-based treatments will be very useful for protecting against both mosquito and tick-borne infections. Okay, so I think that is the summary of my slides. I can look over here to see if there's any questions on the chat box.
Thank you, Dr. Caplivski. Dr. Patel just put a question in the chat. Let me know if you want me to read it for you.
Yeah, I can read it out loud. Yeah, so you mentioned that gene sustain can be helpful in the diagnosis of Leishmania. In working on patients presenting with pustular ulcerative lesions in which zoonotic cause is suspected and differential diagnosis is broad, is there a panel of other stains you would recommend sending aside from the typical gram stain and culture? That's a great question. So basically, with let's say a cutaneous lesion that you might suspect Leishmania, your typical gram stain may be helpful, just kind of excluding, let's say, a really bad case of Staph aureus, furunculosis, or something like that. The typical GMS stains that we sometimes ask for fungal infections, silver stains, I think, can be useful. Just because if it's an HIV patient or someone who's immunocompromised, sometimes you'll see histoplasmosis or some of these other fungal infections presenting in different ways that you might expect. So, if you've got Gms, Gram stain, and GMS, that's already going a long way. Cryptococcus, Cryptococcus typically is a more umbilicated lesion, which is a little more popular. So if we're really suspecting that, you'll usually see it on the silver stain, the GMS, but there's a mucicarmine stain that's pretty specific for that. That can be also very useful. And I think for all the viruses, it's tricky. I think for the pathologist, they have a hard time. Let's say if it's you're suspecting varicella versus HSV, you've got some antigen tests there that can be useful. But I think just on H&E for them, it would be hard to say.
Any other questions from the group?
Yeah, I do.
Oh, Hayato, I'm seeing your question now. I can read it aloud if your audio is not working.
Yeah. So I have a question on the initial management of babesiosis. Yeah, you mentioned it's indistinguishable between malaria parasite and also babesiosis. So when blood smear comes back as a presumed lead as Plasmodium species, even when you don't have any suspicion for malaria parasite with zero exposure to endemic areas in patients with clinical features consistent with babesiosis. In this situation, is empiric treatment for malaria justified in addition to a babesiosis treatment?
Yeah, thanks, Ayat. That's a great question. A lot of times we go into the microbiology lab and we'll look at a peripheral blood smear. And for the microbiologist who doesn't have any travel history, all they're looking at are rings inside of red blood cells. They have a really hard time, distinguishing the two. If I go back to all these peripheral smears, I just want to go back to the Babesia pictures because I think it's, these things are so tiny, and if all they see is this intracellular ring, and they don't see the four little, sort of merozoites in that Maltese cross classic formation, and then they really don't have a lot of confidence to say, well, this could be Plasmodium versus Babesia. So usually we're at an advantage because we can get some travel history, and we'll be able to kind of tailor our decisions based on, well, it's someone who's never been outside the country, and they're just back from an upstate camping trip or something like that, and usually that'll give us a confidence. But I'd say sometimes it's more challenging. You don't have all that information, and then it gets into the severity of illness. So if it's a relatively mild case, where they're awake and alert and they can tolerate oral anti-parasitics, usually have plenty of room to start with your atovaquone and your zithromycin and just see how things go. But if they're in the ICU intubated and they're in, severe Plasmodium versus Babesia infection, then it certainly is okay to try to expand the realm of possibilities and treat for both. Just a comment on the current state of affairs with severe malaria treatment. So in the past, we were using things like intravenous quinidine because we didn't have access to IV quinine, which the rest of the world would use together with something like doxycycline for severe malaria. But the supply of quinidine ran out in 2019 because no one was really using it for treating arrhythmias. And there were not enough severe malaria cases for the company to really justify continuing manufacture. And there was a new agent that was much more effective, which is intravenous artesunate. So between 2019 and about last month, we were kind of relying on the CDC for their drug supply of IV artesunate under still kind of an investigational new drug supply scenario where it had been FDA licensed, but we didn't really have access. Excuse me, it had not yet been FDA licensed, but we had access through the CDC. So now IV artesunate is FDA approved, but its availability in most pharmacies is still pretty limited. So if you do have a severe malaria case, a phone call to the CDC, and they've got a stock of it at JFK Airport, and they can get it to our New York hospitals in a fairly quick turnaround time. So if you didn't know, and you were treating for babesia and severe malaria, that could include things like the quinine, the Clinda, the atovaquone, and then maybe the artesunate as well. So I would say yes, there are scenarios where that could happen. Most of the time, you can get enough clinical background to help in that decision as well.
That makes sense. Thank you very much, Dr. Caplivski.
All right, it is a little bit after 1 o'clock, so I think we'll end it there. Thank you again, Dr. Caplivski. Have a good day, everyone.
Thanks.